Myringoplasty, Chapter 83 by P L Dhingra. Closure of perforation of pars tensa of tympanic membrane is called myringoplasty. It has the advantage of 1. Restoring the hearing loss and in some cases the tinnitus. 2. Checking repeated infection from external auditory canal and eustachian tube. Nasopharyngeal infection ascends more easily via eustachian tube in the presence of perforation than otherwise. 4. Checking aeroallergens reaching the exposed middle ear mucosa, leading to persistent ear discharge. Myringoplasty should be differentiated from type 1 tympanoplasty, though both refer to repair of tympanic membrane. Tympanoplasty entails exposure of middle ear to inspect the middle ear and also ensure ossicular integrity. Myringoplasty can be combined with ossicular reconstruction when it is called tympanoplasty. Physiological principles for middle ear reconstruction are discussed in page 34. Complications 1. Active discharge from the middle ear. 2. Nasal allergy. It should be brought under control before surgery. 3. Otitis externa. 4. Ingrowth of squamous epithelium into the middle ear. In such cases, excision of squamous epithelium from the middle ear or tympanomastectomy may be required. 5. When the other ear is dead or not suitable for hearing aid rehabilitation. 6. Children below 3 years. Anesthesia, local or general anesthesia, the former is preferred. Position supine with face turned to one side, the ear to be operated is up. Graft materials used 1. Temporalis fascia, most common. 2. Areolar fascia, overlying the temporalis fascia. 3. Perichondrium from the tragus. 4. Cartilage. 5. Vein. 6. Periosteum. Incision for exposure of tympanic membrane depends on the size of the ear canal. It may be endomeatal, endoral, or postoral. Technique. Underlay technique. 1. Grafting, harvesting the graft. Example, the of temporalis fascia or perichondrium from the tragus. 2. Preparation Preparing the tympanic membrane for grafting. An incision is made along the edge of perforation and the ring of epithelium removed. Remove also a strip of mucosal layer from the inner side of perforation. 3. Inspecting the middle ear. A stapes type incision is made and the tympanomeatal flap raised to see the integrity and mobility of the ossicle chain and to ensure that no squamous epithelium has grown into the middle ear. Placing the graft. 4. Middle ear is packed with gel foam soaked with antibiotic. A proper size graft is placed so that its edges extend under the margins of the perforation all round and a small part also extends over the posterior canal wall. Tympanomeatal flap is replaced. An underlay technique has the advantage that the squamous epithelium is not buried in the middle ear. Overlay technique. 1. Temporalis fascia or perichondrium graft is harvested as above. 2. Incision is made in the meatus as shown in figure 83.2 and meatal skin raised along with the all epithelium from the outer surface of the tympanic membrane remnant and preserved to be used later. Figure 83.1 Myringoplasty underlay technique. Fascia graft is under the anterior annulus. It is supported by gel foam in the middle ear to prevent medial displacement. Perforation, bone, skin of canal, graft. Figure 83.2 overlay technique. A. Incision to raise medial meatal skin with tympanic membrane epithelium. B. Placement of graft. C. Replacement of skin. Temporalis fascia graft, raw bone. Replace skin. 3. Graft placed on the outer surface of tympanic membrane. A slit is made in the graft to tuck it under the handle of malleus. 4. Meatal skin is removed earlier, is now replaced, covering the periphery of the graft. 5. Ear canal packed with gel form and then with a simple antibiotic, small antibiotic pack. A modification of the overlay technique is to be place the anterior edge of the fascia graft under the annulus after removing the epithelium from its undersurface. This prevents blunting of the anterior canal, which is seen as a complication of overlay technique. 6. Closure of endoral or post-oral incision. 7. Mastoid dressing. Figure 83.3 Myringoplasty overlay technique. Fascia graft lies lateral to anterior annulus onto the anterior bony canal wall. It is placed medial to medial handle, malleus handle to prevent lateralization. Graft malleus meatal skin anterior annulus. Post-operative care. Stitches are removed after 5 to 6 days. Ear pack is removed after 5 to 6 days without disturbing the gel form. 3. Patient is seen at 3 and 6 weeks after operation. 4. Complete epithelialization of the graft takes 6 to 8 weeks. Complications. Underlay technique. 1. Middle ear becomes narrow. 2. Graft may get adherent to the promontory. 3. Anteriorly, graft may lose contact from the remnant of the tympanic membrane, leading to anterior perforation. Overlay technique. 1. Blunting of the anterior sulcus. 2. Epithelial pearls. They are epidermal cysts when squamous epithelium is buried under the graft. 3. Lateralization of graft. Graft loses contact from the malleus handle, resulting in conductive loss. It is prevented by tucking the graft under the handle of malleus. Other procedures for closure of tympanic membrane perforation. 1. Splintage. It is used to freshen the traumatic perforation. The torn edges of the perforation are carefully everted under the microscope and splinted with absorbable gel form placed in the middle ear through the tear. Smaller tear can be splinted on the outer surface of the tympanic membrane with a piece of cigarette paper, gel film, or silicone sheet. 2. Cautery patching. This is useful in small, long standing central perforations where the margins have become epithelialized and chronic. In this procedure, margins of the perforation are cauterized with 50% trichloroacetic acid to remove the epithelialized edge or freshened with a fine pick used for myringoplasty and then supported with a cigarette paper moistened with 1% phenol in glycerin. This procedure can be repeated at 2 weeks interval. Instead of cigarette paper, other materials such as Terrestrip, gel form, or silicone sheet have been used. 3. Fat graft myringoplasty. It is used to close small perforations after local anesthesia. Edges of the perforation are freshened with 1 millimeter stapes hook. The inside of perforation is also scraped. A small piece of fat harvested from the ear lobule is plunged into the perforation like an hourglass. Over time, the fat graft adheres and closes the perforation. Thank you.